Welcome to the Residency Match Insiders. Today's topic is, have you ever received negative feedback in your life? And I want to say, of course, I did, or I had, and probably you had too as well. And remember, medical school, the last year of medical rotations in your country, the process to come to United States and try to match for a residency position is all a learning process, right? You didn't start knowing everything. So I was a terrible student in medical school. Terrible. I received so many negative feedback in my life that every time I got it, I had to take action and try to overcome the problem I was having. So this is important for medical residency in the United States. Why? Because every program is proud to have faculty that are mentors for the future doctors of the community. That's even their mission statement, that they focus on mentoring the new doctors, the new generation of doctors, to treat the underserved, the underprivileged, the people that are marginalized. So taking that in consideration, let's look at this question as, why is negative feedback so important? First, because it makes you aware of you as a doctor, as a person. It makes you, or gives you the opportunity to self-improve or to grow. And most important, most of the times we're not able to see that ourselves, but someone else that is looking at you can say that. And this is oftentimes, most of the times, or every time during residency, the attending physician that is supervising your work. The way it works in internal medicine, family practice, pediatrics is the main rotations that are outpatient clinic or inpatient services. You present cases, or you work up cases presenting to a supervising physician that will say, okay, I like your plan, I like your thoughts, I like how you work up this patient, I feel confident that this is not pulmonary embolism, so go ahead with your chest pain workup. So think about that. Think about that person as supervising. This person is putting his trust on you to be his eyes and hands at the hospital. Same at the outpatient clinic. At the outpatient clinic, you get a quick session with the patient, then go inside the room with your preceptor and say, hey, this patient is coming here for hypertension checkup, his medications are this, and I plan to do this and that. And the same, they supervise you, and at the end of the month, they give you feedback. Sometimes they also do video supervision of students or applicants or residents, and once you go back, the feedback is bigger, is greater, because they were able to see and listen what you were saying and doing, or what you didn't say. So all of these are opportunities for you to find improvement, to find an area that you need to work on. So we love feedback. We are grateful for critical feedback. We want to give feedback to students. We want to be mentors to others. And thank you for helping me not to suck as a resident. That's something that to keep in your mind. Okay, keep that in your mind. And in order to find a good answer for this question, let's try to figure out what is feedback. Of course, feedback is me saying the areas of improvement, what you did good, and evaluating your behavior, your knowledge, all the aspects that are critical for a good doctor, right? But beyond that, there must be a technique to give feedback, and I'm going to tell you there is a technique to give feedback. That's why there are so many faculty development programs nowadays where supervising physicians go to to improve on their ability to give feedback and their ability to be mentors to teach residents. It used to not to be like this in the past. It used to be just, I just want to supervise residents and it's an easy job. It used to be like that in the past, but not anymore. Now programs are expecting more from the supervising physicians. Programs are expecting for residents to get a really good evaluation and a really good opportunity to learn. So what is the model to be able to provide feedback? So when you have a student, you first evaluate what they are saying. So you listen to them, and it is kind of approaching a patient. So you listen to them, you create some questions in your mind. What are the areas that this student could be lacking on, or could be some need on? And then you identify those areas that he may be having trouble with. And now, depending on the area that it is that you think there's a problem, you can take action on. Now, for the way that the framework for giving feedback has been created, you have to identify areas like professionalism, knowledge, language barriers, problems like depression, drug abuse. So once you identify one of these areas and you can take action, then there you go. Feedback cannot be always positive, because then that will be us making you very, very confident and perpetuating bad behavior, or not being able for you to grow. Feedback has to be critical and has to help me realize that there are areas that I need to work on. So for this particular question, I'm going to give you my answer, and hopefully what I have been saying helps you to find a good case for you. You can always send an email to us and run your answer through us, and maybe we can tweak it for you and help you, put the right words on perspective. So my answer for this question will be feedback, negative feedback. I love feedback. I'm very happy to have an opportunity to be evaluated and receive feedback, and also to be a mentor for others and be able to give feedback. I had an experience in the past where I was told by one of the supervising physicians in medical school that I wasn't cut to be a doctor, that I should look into something else. And it made me very, very sad. It made me think for a while that, is this true or not? And I had to figure out what was going on. Why would this doctor say something like this? And I thought, it's not personality, because he was very, very friendly, very easygoing. It may be cultural. It could be cultural, but to be honest, at that point in my life, I wasn't a great student. I was lacking in some reading, and I didn't have good amount of knowledge. So at that point in medical school, I said, I'm gonna have to start reading double or triple. I'm gonna have to start reading late hours now. And I did for a couple of months, and then it turned into years. And then till now, every time I see a new case, I go back to my books and I start looking at physical exams, case reports, recent research about these cases, what is new on these cases. And I will never forget what he said, because gladly it's not true. I'm here, and it had a big impact at that moment, and it still has a big impact for now. At that moment, it may be very sad and it devastated me, but now I feel like it has helped me create discipline and a method. I follow a method. I see a new case, I don't wait, and I don't wait too long for me to be able to read about this case, investigate more about this case, and even create a short presentation for my peers. And so far it's working great. From this experience, I learned that to be a mentor, to be an educator, it comes with many responsibilities. It comes with your words having a big impact on your students, and that's why every time I have a student or someone that I have to supervise, I try to give them critical feedback. I think it's important, but also I try to give them what I think could help them to improve or overcome this little problem. And it has worked great for me. So feedback, very important. So that was my answer. I like it. I like it because I am part of a teaching hospital, and we have students. We have to give feedback all the time. At the end of the rotation, it's expected from us to give feedback, and we were told, okay, so this is the way, guys, you have to give feedback. And I will tell you something like, okay, let's go out to a private room, and then we sit and start talking. How do you think you did? What do you think you did not that good? And what do you think are the areas that you excel at? Do you have any particular case that you will remember when you leave? Do you think there's something that I can answer for you before you leave? And it is a short conversation, but we like to do when it's my time to give feedback, I like to give the good first, what he did good and his strengths, and I try to do more strengths, a lot of strengths, because when the time comes for me to give negative feedback, it doesn't affect them that much. So I don't want to really destroy a student, making them think that they don't know what they don't know because they're students. But I want to tell them, this is an area where we can maybe focus a little more and put a little effort on creating a wider differential diagnosis list, or to ask more questions to try to really find the answer, or try to find clues to help us make a diagnosis. Most of the times when we talk about international medical graduates, the problems are different. Knowledge is one, in terms of not knowing how the outpatient or the inpatient rotations work, how to create an HMP, and the important parts of the HMP. Here, as I said in previous videos, one of the important parts is to identify goals of care from the very beginning. Another important part is to create a differential diagnosis list and elaborate on your assessment and plan part. In my country, for example, in Peru, I don't know, when I was a medical student 15 years ago, the HMP wasn't done like I do it now. The progress notes weren't done the way I'm doing it now, or the discharge summary wasn't done nearly as close as the discharge summary I have to do now, even in my position as an attending. So that's one area, and it's mainly not knowing the system here. The second area is professionalism. Coming to work late, not finishing rounding your patients on time. I used to think that, okay, my peers are seeing 6 patients in 1 hour and a half, so I'm fine coming to work at 7, so I can present by 9. But it wasn't true. It wasn't me. I not only had to deal with language, the system, the electronic medical records, but I wasn't at the same speed as them. I didn't know how the telemetry unit worked, where to look for EKG strips, where to look for lab results. So it took longer for me, and I really had to come to work at 5 a.m. to finish up my 6 patients and have a plan, because when you present those patients, you need to have a plan saying patient has problem number 1, decompensated CHF. So his urinary output for the last 24 hours is 3 liters, and this is a net negative balance. He is diuresing nicely. We continue on Lasix IV or change to Lasix PO, thinking that he is about to be discharged probably in the next 2 days. We'll increase his beta blockers to maximum tolerated dose. We'll adjust his ACE inhibitors to maximum tolerated dose and monitor his creatinine levels. I think that the reason for his decompensated CHF is medication non-compliance, things like that. See, it's not it wasn't as direct as I was doing my presentations in my country, because the expectation here from your supervising attendants is way bigger. It's the expectation is for you to think about everything you are doing. So on that note, feedback is very important. Hopefully you get some ideas from this video, and we'll continue to send more videos every week, and try to post something on Facebook once a week at least.